The Coalition of Texans with Disabilities, Raise Your Voice 2022, Health Equity and Biomarkers, September 26th, 2022.
Thank you, Laura. And today we, as Laura said, we're going to be discussing a little bit about health equity and how that affects Texans with disabilities and just all Texans. And one of the exciting things that we're going to kick it off with that I've gotten to work on a little bit, and as y'all all know, we do work a lot with kind of in the pharmaceutical area and medical side of policy. And one of the more exciting things is where we're going with some of this new technology and how it's getting out there and how it can really affect and change the way our lives are. And that goes with precision medicine. So there are some really remarkable research being done, a lot of amazing treatments coming out. And with that is a cost that comes with that. A lot of these medications are very expensive, but they're very effective and very useful. But there's also some tools out there that help, especially in the fight against cancer. And I think Texas took a big lead in cancer research over the years with CPRIT, with the MD Anderson, and some of the other research being done in Texas. And one of the areas that makes a really big difference in precision medicine is testing and making sure those medicines will work specifically for that person in those circumstances. And that can be done with biomarker testing. And we wanted to bring on today James Gray, who is the Government Affairs Director, I believe that's correct, with the Cancer Society, and have him kind of explain where things are at with biomarker testing and some of the things we need to do, because we are starting to see some health equity issues in some of these new issues and wanting to make sure everyone has access to them. So we thought this would be a great way to kick off this discussion around health equity. And we know that cancer affects everyone. It affects families, it affects pretty much everyone at some point in their life. Will know someone, will go through it themselves. I know I've had a lot of close friends that have had to deal with cancer. So the steps and the progress we're making are really exciting. And we kind of wanted to bring James on to talk about biomarker testing, how that can help with precision medicines, and the next steps of what we need to do going into this session, and any possible legislation that's been filed that all of y'all can help on as the session goes. So James, I'm going to turn it over to you, give you control and let you kind of talk about this issue, and we'll go from there. Oh, you're on mute still.
Thank you. So James Gray, Director of Government Relations for the American Cancer Society Cancer Action Network. I am working in my home office today. So behind me, I have some pottery from a few pueblos in New Mexico, the Acoma Pueblo and the Ute Pueblo. And then I have a photo of my wife, but at the time she was my date, in front of the Portland Head Lighthouse in Portland, Maine. So, and you might hear some noise in the background. I'm in one of those neighborhoods in Austin where they're tearing homes down, and the one next to me has been torn down, and they're cleaning it up today. So I apologize for that. First, let me just say, I'm so appreciative of the work that the Coalition of Texans with Disability does. I get to work with Chase and Dennis and have worked with them for years, and more importantly, kind of seen the impact that they have in the Capitol. And what they do and the voice they bring into the Capitol is so well respected, but more importantly, so effective. I work in an organization that is led by volunteers. So patients, physicians, survivors use their experience, like all of you, to shape public policy. And I will be honest, when I talk about what we do and why we do it and how effective it is, I use the coalition as an example of how effective you can be in the fight against public policy. So your work is being seen, and more importantly, your work is having an impact as a coalition, but also as advocates. So I want to talk a little bit about biomarker testing, and I think Chase it really is interchangeable. It's precision medicine, it's biomarker testing, and it does affect a range of diseases. So I'm going to talk about this through the obvious lens, which is the cancer lens. But if you had someone here talking through the rare disease lens, they would talk about the potential that we're seeing in rare disease, neurologic diseases. We're starting to see a significant impact from the ability to use biomarker testing and deciding the treatment for these individuals. So, a really good kind of, and I want to show a video in a minute, but kind of a basic overview, a simple overview is, and it wasn't that long ago, and even in some cases now, if you were diagnosed with cancer, you had a certain type of, let's say, prostate cancer, they would treat it and they would find out how that cancer is responding to your treatment. And so it was kind of a fail first. Let's try that and then try something else. Now on the front end with biomarker testing, we get to look at your genomic makeup of that particular cancer tumor and determine what treatment will have the greatest response to that particular tumor that you have, right? So, some researchers and doctors will sit here and tell you that, they won't treat breast cancer in 20 years. They'll treat a specific genomic mutation that will be in the breast. And that's kind of where we're going with the fight against cancer, which is so exciting because we all know catching cancer early is one of the ways to survive it, but more importantly, getting the right treatment is another way to make sure you're surviving cancer. So I'm going to share my screen and then try to just share this short little video that I think does a much better job giving the kind of technical overview of what a biomarker is. And let me see if I can do that. I'm not used to Zoom, but that's no excuse. That going up on your screen?
I'm not seeing it, James.
Not.
Let me try to mess with some settings. Okay. See if you can hit that share screen button now.
All right, hold on one second.
Sure.
And if it doesn't, all right, there we go. How's that look?
Great. Got it. Oh, we don't have sound.
You don't have a sound?
We don't. And here's what you'll do. End the screen share.
Okay.
We're just going to start from the beginning.
So do new share or end share?
End.
Okay. Laura, it's not critical to the presentation if this is too cumbersome.
It's up to you. It's just a matter of checking a box that allows you to share your sound when you first hit that share screen button.
Let me start share screen again.
Yeah. And there's a little checkbox that should be at the bottom left
there it is.
corner.
Thank
Yep,
you.
that's it.
Thank you. I'm gonna just go back to the beginning.
New way to use information from your own genes or proteins to help doctors diagnose or treat disease and improve survival and quality of life in conditions like cancer. Well, biomarker testing is here, and it's full of promise. Now imagine this: thousands of Americans who could benefit from this scientific advancement missing out because of lack of insurance coverage and other barriers. Americans who have been marginalized, including in communities of color and those who are insured through Medicaid, and people in rural communities far from academic medical centers, are less likely to benefit from these life-saving advances. A biomarker is a unique signal that is specific to a patient's disease and can be measured in blood or tissue. In cancer, biomarkers can include molecules like proteins and gene mutations found in cancerous cells. Cancer biomarkers are often notated by an abbreviation which can include numbers and letters. A positive test means the patient's cancer cells have that biomarker, and this information can be used to select the most appropriate treatment. Scientists are working to advance new treatments for cancer and other diseases by determining what biomarkers can convey about the effectiveness of different therapies. Currently, there are rapidly increasing numbers of biomarker-informed therapies doctors are using, and these therapies are leading to improved survival rates and better quality of life for people with cancer. And those better health outcomes could lead to lower healthcare costs. But private and public insurance plans are failing to keep pace with this progress. As biomarker-informed care continues to advance, ensuring equitable access to biomarker testing by improving coverage will be key to preventing new health disparities and dismantling barriers that prevent too many patients from benefiting from these innovations. So even if you're not a doctor or a scientist, you can help bring the promise of biomarker testing to all Americans who need it by supporting a law to extend coverage for biomarker testing and by educating friends, family, and policymakers about the importance of biomarker testing. Join ACS-CAN in supporting policies that will ensure coverage of testing for patients, including those insured through Medicaid. Improving access to biomarker testing can lead to better patient outcomes and advance health equity for all.
Great. So hopefully that, well, you guys.
No, it explained things well, James.
This is one of those situations my kids would just laugh at me and say, "Dad, what are you doing?" Can you, I'm back on camera, correct?
We can see you now, yeah.
Great. So I think that's a pretty good overview. And I think what was important in that video is the rural and the economic inequities of biomarker testing. So and that's why a piece of legislation in Texas is so important. Getting legislation passed that really requires a level playing field for state regulated insurance companies to reimburse for biomarker testing is going to be so important. And many of the access issues that we have faced or cancer patients have faced in the last 30 years have been really because of the success of public policy. Interestingly, back in the 80s, well before my time, if you talk to someone in my seat, they would tell you they were advocating for mammograms to be covered in state insurance. That issue has been fought and won, and some of the greatest achievements we've had in improving access for cancer patients has been through public policy. We see this as one more step in the direction of providing access and really creating more equity in the fight against cancer. So making sure that individuals, cancer patients in rural communities have access and get reimbursed for biomarker testing. Make sure those on Medicaid here in Texas get coverage for biomarker testing. So we are working with a broad coalition and really appreciate the support of the coalition and Dennis and Chase and helping us educate elected officials, bring together a diverse group of stakeholders to really put a face and a voice to this issue, and then get the legislature to do what we know needs to be done, and that is pass legislation that would provide these assurances for Texans to make sure that when the time comes for them to make a decision with their doctor on what treatment is best for them, there are no barriers on whether or not biomarker testing becomes an option in the decision they made and what treatment they pursue. So I'm probably well over time, but I'm happy to answer any questions, but love to keep you updated as we kind of go through the next session. Mandates are never well received in the Texas legislature, as you all know. But when we do what you all do so well, and that is put a face and a voice to the issue, it becomes a very different discussion. So that's what we are doing in this campaign, and I'm glad you guys are a part of it.
Yeah, and James, this is something that we've all discussed over the years, that when patients get put first and we get early treatments, people have better health outcomes. That is how you make an actual cost-effective healthcare program in Texas, instead of being a reactive healthcare program, which is currently where we're at. This moves us to that next step of really, the potential of all that research that we've been doing to really improve health outcomes. And to do that, we have to make sure it's available for everyone in Texas. And that's where y'all are working. Y'all currently have some legislation being drafted or worked on to bring this issue to the next session. And that's where we can all support y'all and make sure that these voices and everyone's voice, because I'm sure everyone on this call probably has someone that, cancer or a rare disease or many of the things that we could be helping people improve their health. This will affect in the near future. So if there's anything we can do for y'all, please let us know.
I appreciate that. And you explained it really well. I mean, this has got to be a decision between the patient and their family and the physician in terms of what treatment they pursue, and having the appropriate data and making that decision is critical to their quality of life. So
perfect. Well, thank you, James, for getting on. And I'm going to turn it over to Dennis, who's going to continue on this theme of health equity and how it affects us all in a bigger, more general area.
Thanks, everybody. Have a good afternoon.
Thank you,
Thanks,
James.
James. Thanks, Chase. So I'm Dennis. I am an Anglo male with gray hair, gray beard, a gray jacket, gray eyes. So just think of me as your friendly elephant. And I wanted to talk to you about health equity in a larger sense than medicine. But before I do, I want to tell you, I was listening to James talk, and I was reminded of an example of health equity legislation related to prescription drugs that we succeeded on. And it was a drug that was made out of, and this is true, I'm not making this up, it was made out of the saliva of Gila monsters, right? Gila monsters. Now, you know what those are? They're like those creatures, in the desert, kind of lizard, big lizard things with very strong jaws. You don't want them biting on you. Yeah, that is a Gila monster. And believe it or not, there's a medicine made out of there that was very effective, but it was not available to many people. And we had to pass legislation to get the Gila monster medicine and other medicines of those kinds, which are now called biologics. You may have heard that term a lot more frequently now. That term is now common. So sometimes health equity comes piece by piece. And what I want to talk to you about today is, again, a little bit larger. Can we move more into health equity on a just overall without doing this every inch by inch along the way? So health equity is achieved when everyone has the opportunity to be as healthy as possible. And those inequities, when there are inequities or disparities, it shows up in length of life, quality of life, rates of disease, disability, preventable early death, severity of disease, and access to treatment. Okay, now let's be real, folks. Do we think everybody in the United States has equal access to healthcare, medicines, treatments? The answer is no, they don't. Okay, and those folks on this call right now may be thinking we're going to talk a lot about people with disabilities, and we are. But it also impacts, say, people who may live in rural areas versus urban areas, people of color, people of low income, people of perhaps different sexual preferences, all these kinds of things, where people, through no fault of their own, just by being who they are, have less access to health. We used to call that disparities, health disparities, instead of health equities. And in my mind, sometimes it makes more sense to call it disparities. But the common term today is health equity. I get that. It's a positive term. And what do we want to do is we want to reduce these inequities. So we want to increase health equity, including for people with disabilities of all ages, of whatever disability they are, of whatever ethnicity they might be, wherever they might live. And so why is that important? Well, I did find some data on this, and it's from 2019, so it's a couple of years old. But if you compare people with disabilities to people without, and sure enough, this is not going to surprise many of you, that people with disabilities have less access to health care. They have more depression and anxiety, engage more often in risky health behaviors such as smoking, perhaps drinking alcohol beyond moderation, and are less physically active. Okay, so, some of those things might be personal choices, but some of those things are not. They're what you're told you have to live with. Now, James was talking about biomarkers. I think he got the idea that these biomarkers, which are pretty new on the scene, are really good things if you have cancer to have access to. It gives you, it's like getting on the highway instead of being stuck on the dirt road along the way. You just go directly to where you might need to be as far as a kind of medical intervention. And that's a good thing. But we know, and this is why Chase and I will be working shoulder to shoulder with James and many other advocates, is to say that these biomarkers need to be available in Medicaid. Okay, so if a Medicaid recipient has cancer, let's give them this biomarker so we can direct them to the efficacy of treatment, which frankly is getting better. I used to think, I'll be honest, my mom died prematurely from cancer, so I hate cancer. And that was a long time ago. And I always thought that, well, cancer is going to be cured. Well, you know what? It's been almost 40 years now and cancer still isn't cured. So we got a ways to go on that, but we've come a long ways too. Okay, so I wanted to tell you all that legislation can result in health equity. And I'm going to tell you a true story about CTD advocacy that resulted in a piece of health equity. Okay, so I am showing you a very ugly looking thing. How would you like to have a bunch of those things in your liver? Well, that would be bad. That would be really bad, because what that is a hepatitis C molecule. Hepatitis C is a terrible, terrible disease that is progressive. It takes a long time. It's hard to detect in its early stages, but when it gets further on, it destroys the liver and can result in death or having to have a liver transplant. Now, this is particularly difficult in, believe it or not, women. Why? Because women used to be given blood transfusions upon childbirth to restore some blood. And at one time, the blood supply in the United States wasn't checked for Hep C. And so a lot of women are discovering in their late 50s or 60s that they've been carrying the Hep C problem, these molecules in their liver for decades, and it's now causing them serious problems and threatening a shortening of life. So it's a terrible, terrible disease. So what is the health equity in this? Well, it turns out that CTD became aware that a medicine was developed to cure hepatitis C, to cure it. That was almost unknown of. That was like, these biopharmaceutical researchers, this is what they live for, to find a cure for something that's never had a cure before. And that became available in 2014. But you know what? It wasn't allowed in the preferred drug list in Texas Medicaid. Okay, this is a cure. This is not, and this would replace, keep this in mind, a cure would replace the need for a liver transplant or the progression of the disease. It would also keep people from having to take lifelong medicines just to try to keep it under control. So this medicine was great. We presented this information to the Texas Sunset Advisory Commission, not the legislature, the Sunset Advisory Commission, and recommended that the Sunset Commission, recommend the laws be changed to include this medicine in Medicaid. And it took a little while, but in fact, we were able to succeed in that. And this medicine became available in Medicaid. But it's never as easy as it should be. So what happened is the Health and Human Services Commission said, well, we're going to take our time. We're going to add it, but we're going to delay adding it. So we started pressuring the Health and Human Services Commission, whose executive commissioner at that time was a physician. And, you know, it was kind of interesting because it didn't take him too long to actually agree. Because even though this was expensive medicine, it was cheaper than a liver transplant, a lot cheaper, actually. But he wasn't going to do it. But he did after we kind of, you know, advocated to him that this is what we needed to do. So now you see, we started with the Sunset Commission, and then we went to the Health and Human Services Commission. All advocacy is not necessarily in the legislature, but it can be. And I'll continue on that. As this medicine became available in Medicaid, they set up a criteria that said you had to be really sick before you could get the medicine. And we, after years of struggling, we finally got them to relax it so you could be at an early stage of the disease when the medicine could be even more effective. So notice these steps we had to go. And I'm going to finish up with what we were able to achieve in the last legislative session, 2021. And that was to make this medicine available to the early disease stage and fund it. And we were able to do that with a Senate concurrent resolution 31 to make access to this Hep C cure available at an early stage and funding it for $51 million. And you know what? We were the only consumer advocacy organization that worked on that piece of legislation. We need more help on that. So let's see, I'm getting to the point where I'm supposed to, I have just a few more minutes. So I told you the background, I gave you an example. So the next thing, and I'm going to get rid of this ugly molecule. There, that's much better. I know I look better than that molecule. So let's look forward. In the next legislative session, there will be a bill filed called the Office of Health Equity Bill. This bill was filed in the last session by Representative Coleman out of Houston. There used to be an office in the Health and Human Services Commission. It was called the Elimination of Disproportionality and Disparities. In other words, it was the Health Equity Office. And it helped the Health and Human Services Commission to identify if there were certain groups, ethnicities, rural areas, parts of the state, communities such as the community of people with disabilities who didn't have access to certain health care, and help HHSC devise plans to make healthcare available. That office was closed in 2017. Yeah, that was not a good idea. So this legislation would restore it and change the title to Office of Health Equity, a positive, a progressive, positive thing. And in addition to helping HHSC plan to eliminate these disparities, would help them implement them. And hopefully my thought is it would help reach out to advisors from the various communities. When I say advisors, I'm talking about people with lived experience. So it'd be people living with disabilities could talk about how access to certain medicines, certain treatments, certain care is better. And by the way, that does include long-term services and supports. Equal access to community attendance services is a health equity issue. This is also going to talk about social determinants of health, which are things that means if you're poor, if your housing isn't good, if you don't have transportation, those are social determinants of health. They make you less healthy. You know, if you have less money, if you live in poverty. So it's going to start factoring in those things. This is long overdue. You know, I think it's kind of an embarrassment that the state had such an office in place and then closed it. Well, it's time to restore that, and the way to do that is with this legislation. It will be filed now. Representative Coleman has retired, so he won't be coming back. But I was able to confirm this week that another state representative is taking it on and filing that bill. So that's a good thing. So that will be filed. So we will keep you posted on how that happens. So Laura, let me ask you this: do you want to give the breakout etiquette, or do you want me to give the prompt first? Because we're going to go into breakouts here, folks.
Right. Before we do that, I see that Lyra has a question.
Oh, yeah, go ahead, Lyra.
Oh, it's in the chat. She says, do you know why they had stated that they closed the office?
Thank you. And by the way, Lyra, I'm so glad you're here. Lyra, by the way, is a UT student who's getting involved in advocacy. How cool is that? He's going to drag along a bunch of other UT students too. Right, Lyra? You can do that. Do you know why they stated that they closed the office? Yes, I do. I do. They stated that they didn't think it was worth the money it was costing. And I'll tell you, we have a saying among advocates, when something is really cheap compared to how much money they spend, we call that, I'll sprinkle my fingers here, budget dust. It's like a grain of dust in the total budget. So what was the real reason they closed that office? Was it really money? I don't think so. I think they just weren't, I think they weren't invested in the idea of health equity. You know, I think they recognized that these disparities existed, and maybe that office was pointing that out a little too much for their comfort level. I can't say for sure, but they blamed it on budgetary problems. But when something is, as I say, a grain of dust in the total budget of the Health and Human Services Commission, that's a kind of explanation that to me doesn't ring true.
Following breakout groups.
I'm going to touch on several things that came up in our group, and then ask if anybody had other things in regarding health equity. And so things we heard about. Doctor wandering, you know, you got to go to a multiple doctors before you get your diagnosis. Go to your GP, then a specialist, then another specialist. That's a barrier. Interest lists for community attendance services, sometimes 16 years long. That's a barrier. You know, like Betty was just talking about how she was responsive to the biomarker conversation earlier about how great that is for people with disabilities, because cancer does strike people with disabilities more so than others. Why? Because unequal access to things like oral health care. See, so the roots of health disparities are almost like multiply as they go around. Transportation, disadvantages in transportation, just getting to healthcare results in a lack of health equity. Cost, physical accessibility, sometimes getting into a healthcare place, getting on an exam table, getting through a narrow doorway. Again, Betty had a good comment about, you know, people with visual impairments trying to use technology like touchpads, or what if you don't have an iPhone? Tools that have become common in accessing healthcare are really not equally as sensible. Any other comments? Raise your hand or unmute.
Yeah. Dennis, this is Chase. One thing that came up in ours that I think really kind of struck me, and I thought about in the past, but Mary had said, when you're looking at like the waivers and you have, you know, people receiving, especially those that are receiving a really robust package, and at age 21, they lose their round-the-clock nursing care and stuff like that, where we kind of have set these age limits of when you can get care up to. And it's kind of like the dental program used to be in Medicaid, where you had a full dental package for kids, but at age 21, there's absolutely nothing. So it's not like people's teeth have healed or they need less care at the age of 21, but we basically have created for aging Texans, and if we consider 21 and one day aging now, where you lose a lot of the coverage you might have had as a child earlier on in your life. So age can play a role in equity in a way that we probably haven't even thought about.
Any other comments about health equity, health disparities that came up in your groups that you want to share?
One thing that we talked about in our group was kind of a subset of the cost issue, where sometimes copay assistance and other such cost help is available, but either the doctor's office that's writing the prescription doesn't know about it, or the pharmacy doesn't know about it. And you have to be pretty savvy to actually find if there's assistance available for a particular kind of drug. There's some people that, you know, they'll get a drug and then they'll have a bill facing them that's $700, and they need this drug, but they don't know how to pay for it, not knowing that there is actually help there. They just, you know, sometimes getting that help, you have to do an application with the manufacturer. Sometimes you have to go through your insurance. Sometimes there's a coupon out there that you didn't know was out there. Sometimes it's simple, like through GoodRx. Sometimes it isn't. Sometimes there's third-party assistance available through a foundation. And not having access to that information, not knowing how to comb through those systems, not having just a simple concentrated resource for all this information is a major barrier for people that are facing high costs associated with their drugs.
Yeah, yeah. There's a high cost, and then you don't have access to the information to help you navigate those costs. Yeah, that's a good one. There's one in the chat that came in from Jolene's group: lack of access to prescribed services under Medicaid or a self-funded plan. I guess as an example, that would be the ABA services for autism, which are in Medicaid theoretically, and in self-funded plans theoretically, but are not all that easy to really get to. In fact, pretty darn hard. So, you know, just because something is said to be available, said to be equitably available, it doesn't always mean that it is. And anybody else? We're going to wind it up here. Marianne, sure. Unmute yourself.
Related to that last one, you know, people might think, oh, Austin, there's, you know, great equity, but you know, one issue that's been going on now for quite a while in Austin is that psychiatrists are declining to participate in private insurance, let alone Medicaid. And unless you have the money to pay them out of pocket, you're out of luck if you need psychiatric care, you know, and that's a big issue. That's a big issue for a lot of people, not just people with mental health issues, but people with like with autism, for example.
Yeah, Marianne brought up a good in our group about that, where if you need certain medications prescribed that have to be prescribed by a psychiatrist and you can't afford to pay to get them to sign that, you know, that becomes a barrier of you know, that you can't get the access to the medications because you can't afford to pay.
Yeah, and I think this brings up you know, this is something that CTD cares very much about and we've been working on for a while, but, you know, mental health and IDD and being able to access mental health services. Oftentimes there are things like IQ thresholds to be able to access mental health services, or you know, these two services are not talking to each other. So we have, you know, the local mental health authorities and the local IDD authorities, and families are led to believe you kind of have to choose one door to get services. So you either get services for IDD or you get mental health services, and it's just not very well coordinated. We personally have experienced some real struggles, like Mary had mentioned, about having access to a psychiatrist, but also if you've got co-occurring you know, diagnoses, it's difficult to get comprehensive care.
I want to thank you all, and you're winding down our hour and Raise Your Voice virtual roundtable today. Really good discussions. You know, a lot of like high level philosophy, you know, rather than specifics today. And that was pretty darn cool. So our next Raise Your Voice roundtable is October 10th. It's going to be about voting. And what is more, I'll tell you, I can't think of a more important topic right now than voting. So I also want to thank the fact that we have sponsors that cover all expenses, so no one ever has to pay for Raise Your Voice. And those are GRAIL, We Work for Health Texas, Amgen, AstraZeneca, Touch of Class, and at the highest level, United Healthcare, Superior Health Plan, and Amerigroup. And today, we had a special sponsor. This was a special presentation and was funded by BristolMyersSquibb, and with some extra support for that. We appreciate all these folks because they're going to allow us to keep doing this. And we think the fact that you guys show up and spend time and listen, and it seems like there's new faces every time, And sometimes there's faces we haven't seen in a couple of months coming back. That's kind of cool too. That this matters. We got to know what we're talking about in the public policy world. Thank you very much and have a wonderful rest of your day.